Welcome to mpnuniversity.tv Clinical Insights. This discussion is about Polycythemia Vera and thrombosis and is moderated by Dr. Serge Verstovsek. Our panel discussants are Dr. Richard Silver, Dr. Rubin Mesa, and Dr. Susan Leclair.
Hello, and thank you for joining us for a discussion on Polycythemia Vera and thrombosis. Let's start discussion about the thrombosis assessment risks that we have in our textbooks. They tell us that patients with Polycythemia Vera can be divided in two groups based on only two factors, age and history of blood clot. And then you have a low-risk patients that are younger and without a clot, or older, or those that had a clot that are at high risk for another clot. Dr. Professor Silver, how do you feel about this?
Well, I think that risk categorization is absurd, frankly. And the reason is that you are dealing with a potentially explosive and catastrophic situation and say, I'm not going to treat it until something catastrophic happens. And so a low-risk patient suddenly becomes a high-risk patient because they develop a significant thrombosis. So you can say, in patients with Polycythemia Vera, the incidence of presenting thrombosis is about 30%. That means that if you don't treat a patient appropriately, that risk will gradually increase. So to me, it's illogical. I have the same problem, but to a lesser degree in patients with essential thrombocythemia, because I agree that in that situation, unless there are other factors which increase the thrombotic risk, such as diabetes, hypertension, hypercholesterolemia, those patients, if they're young and not on birth control, those patients can be followed with aspirin. But I think if you're sitting, I often say this is like a woman comes into a doctor and says, I have a little lump in my breast, and the doctor said, well, it's not bothering you, go away and let me know if it gets bigger, and the lady comes back with metastatic disease. So I don't agree with that categorization at all.
But I just chime in. I strongly agree with my colleague in that I've seen many patients under the age of 60 that had a serious blood clot, that by definition, before they had the blood clot were low risk, and then after they had the blood clot were high risk.
But isn't it also written in a textbook that providing a baby aspirin would be protective to some extent, and we give baby aspirin to everybody?
So Serge, that's a common fallacy, because low-dose aspirin only protects against microvascular thrombotic disease. It does not protect against large vessel disease. And that was emphasized many years ago by an English hematologist, blocking on his name right now, who distinguished between the effect of aspirin in high-flow big vessels in comparison to low vessel disease. And what is of particular interest is that in the ECLAP study that was reported in the New England Journal of Medicine years ago, our colleague, Dr. Spivak from Johns Hopkins, emphasized this point. I think he was the first to pick up on the English hematologist reports about the difference in flow and complications thereof in patients with Polycythemia Vera. And that would go along with Rubin's comment that many young patients will develop catastrophic thrombotic events such as superior sinus thrombosis, spinal vein thrombosis, etc., and they're under the age of 60.
That's a really good discussion, but let's take a look at a little bit of a laboratory view. What does the aspirin role is in this disease, and should we then, based on what we just said, think about alternative, different kind of antiplatelet or anticoagulation factor for all the PV patients?
Well, in the microvasculature, what the platelets want to do is to change from a round spherical or oval kind of thing to an interlaced star formation. And what aspirin will do for you is to prevent this stickiness to make the star formation, so that these cells will bounce off of each other, hopefully, and not do this. Well, there are many ways to stimulate this transformation from oval resting platelet to a star formation. And they can be as common as a fever and as rare as some of the rarer platelet disorders. We can test for what the aspirin is doing to a group of platelets that you give us. We cannot put those platelets, though, into the in vivo situation that you are going to deal with, which is this person a person with a chronic inflammatory disease like lupus? Does this person have, I don't know, a history of a crushing wound in their leg, which has nothing whatsoever to do with the advent of P. vera, but does provide you with an environment that would further stimulate those platelets? Well, in those kinds of instances, probably something like an 81 milligram aspirin might not give you the kind of coverage that you want, because all I'm doing is just making them a little less willing to interlace with themselves in the microvasculature. In that instance, maybe you do need other anticoagulants, but we don't have very many choices of testings for those.
So that calls for clinical studies in patients
Yes.
which traditionally would be labeled as a low risk for thrombosis, PV patients, to randomize them prospectively to use aspirin or alternative antiplatelet or anticoagulation agent rather than introduction of a cytoreductive therapy, which is always an option.
But Serge, this risk categorization came from one country in Europe. It's not, and their prolific writers are Italian colleagues, and there are many of us who don't agree with that risk assessment at all.
So you would treat anybody?
No, I didn't say that. I said it depends on, in polycythemia vera, it depends on the number of phlebotomies that these patients have and their symptoms and their physical findings. But in general, the average number of phlebotomies per year is 8 per year for an active patient with polycythemia, and that is not sustainable without cytoreductive therapy. And it was shown years ago that those patients that have unopposed cytoreductive therapy have an increased predisposition to develop myelofibrosis. And in our experience, and this is anecdotal, but it was also reported by the PVSG, it's about 7 to 8 years. So that's why we have a tendency to treat irrespective of whether patient's categorized by some artificial cutoff point of 60. What if they're 58 years old? I mean, you just tell them, no, you wait and come back in 2 years if you don't have a thrombosis?
Rubin?
I was going to say that as we look at the burden of having PV and the decision around therapy, one, I think in the future we probably will treat all patients with PV, and that I think phlebotomy and aspirin over time, I'm just putting that out there, is probably inadequate therapy for a chronic leukemia. And that conservative approach has largely been driven by fear of the complications of the medicines that we've had. So I suspect in the future everyone will get some sort of therapy. Now the burden, I think, is really multifactorial. I think much has been focused around the risk of vascular events, but I think that's only an aspect of the burden. I think the other important components that we've clearly seen is one around the burden of the symptomatic burden that patients can have, and really around the risk of progression. So I consider the vascular risk in that mix, but I don't think it really is only there, in that patients might have very severe pruritus, headaches, other difficulties that they experience with the disease, or debilitating fatigue, even if the risk of thrombosis isn't there. We did an analysis that has been presented at prior meetings with the CytoPV study in conjunction with our colleagues in Italy. They found that the group that had hematocrits of 45 to 50 did have a higher risk of vascular events. However, we also found that the iron deficiency, by being kept lower than 45, did invite other symptomatic difficulties. So the issue of vascular events and symptoms are not necessarily completely aligned.
Now let's move on to a case where we would have a patient with a vascular event, a clot. That patient would be then obviously high risk for clotting again, and it would be started on cytoreductive therapy. What about anticoagulation for this patient? Is it equal for everybody? Depends on the site where the disease is or the clot is. How do we approach that factor? Dr. Silver?
Well, is it a spinemic vein thrombosis or a...
Does it matter where the clot is?
Oh, well,
For the duration of the therapy?
Is it superficial Is it a superficial
So how do you
venous
judge
thrombosis?
that? How in your practice
Well,
you judge that?
when in doubt, examine the patient, I guess.
In fact, so in terms of duration of the therapy and choice of a therapy for more of serious splanchnic vein thrombosis or PE versus a DVT, how do you approach the patient? What is your guideline that you would provide the junior faculty like me?
Well, I've been recently influenced, and maybe Dr. Leclair wants to comment on that, but I've recently been influenced by the article in Blood and elsewhere indicating that superficial venous thromboses are not so benign. But before reading that article, we would treat a patient for 6 months and call it a day. On the other hand, if a patient has Polycythemia Vera and splanchnic vein thrombosis, and then that includes portal vein thrombosis as well, we would certainly continue oral anticoagulants on that patient for unless there was some contraindication.
Whatever.
Forever.
I think it's really an unanswered question, and as I struggle with patients, it depends on many things. In particular, are there other additional risk factors for the vascular event in addition to MPNs? Was there a strong predisposing reason for having the thrombosis? A joint surgery, a prolonged travel, or things of that nature. So I try to look at all those factors, as well as what is the risk of having the patient remain on warfarin or anticoagulation. Is it someone in which that is a high-risk feature or not? But I do tend to be conservative about trying to avoid stopping the warfarin unless I have a fairly strong, clear sense that we have made a major dent in decreasing that risk. I view the prevention of thrombosis to be a very multi-layered activity. It's around control of the counts, it's around anticoagulation, it may be around antiplatelet therapy, and it may be around other lifestyle and risk factor issues as well.
Yes, I absolutely agree, Rubin. I thought I was giving a very specific answer about duration of anticoagulation, but we certainly have to address all of those other issues, which are hardly peripheral.
Now, we also mentioned that many patients, maybe even a third of the patients, present with a blood clot, and that is leading us to work up the patient and find the PV. Should therefore, in any patient who has a significant blood clot, testing for JAK2 mutation or even beyond that be standard practice? Dr. Leclair, what's your opinion on that?
I would have to see the CBC. If you've got a person who's at the moment obviously having a blood clot, but also has a red count of, I don't know, 4.2, no, I wouldn't bother doing the JAK2 because it's almost contraindicated in that sense. If you've got someone who's got a red count that's in the high 5s, or a hematocrit maybe in the 40, if he's male, 47, 48, which is not really a clear cut, but might be an early stage of progression that might be reasonable to do. But to do it for everybody, no, I don't think there's a one size that fits all. And I think one of the other issues on that is if this is the first time you've seen this patient, whether it's in an emergency room or an office setting, the statistician in me would like to know where they've come from. Because while probably it's not true in the United States, in Italy and France and in other countries that have mountains of 14,000, 15,000 feet, that red count's going to go up just because of the oxygen deficit that's up there. Now, we're never going to all go to climb Mount Everest, so we're not going to have to worry about that level, but if you've got someone who's been living for a while in the mountainous regions and they come also with a blood clot and they've got a hemoglobin of 47, 48, it might be hard to distinguish, and that too might be a place that you might want to get a JAK2 just to be sure. But there's got to be reasons for it.
I'm bringing this up because there are studies, retrospective analysis of patients with splanchnic vein thrombosis in particular, that up to perhaps even half of these patients are positive for JAK2 mutation without evidence of any other features of the disease.
No, you're absolutely right, Serge. So I think anybody with a splanchnic vein thrombosis, JAK2 should be a standard evaluation. I think that the question you asked Dr. Leclair was anybody who has a thrombosis. I
So
think if someone has a
specific
superficial
situations like
thrombosis, if they take a long trip from back to Europe from the United States or vice versa, or there's a cause, I don't think it's necessary. If they don't have an abnormal blood count or some other abnormality on physical examination, I think it's very important for our audience to remember that when you have a splanchnic vein thrombosis, there is an increase in plasma volume, so that therefore the red count and the hematocrit may not be high. The only way you can really determine an increased red cell mass, which unfortunately not many institutions do, is by doing a chromium 51 red cell mass study. But in the absence of that, I would certainly urge a JAK2 determination. That's so trivial now.
No, I would agree in that, in particular, that vascular distribution, and perhaps also dural venous thrombosis,
Sure, I agree.
you know, they are unusual enough and they have a strong enough tie to MPNs that I might start with the JAK2, but I might also consider some of the new molecular markers as they evolve. You know, this is not solely a PV-related issue. It could occur in ET or MF. So I might also, not all at the same time, but might consider CALR or MPL or other markers. And that there clearly is some tie in those unusual sites of thrombosis and MPNs.
In terms of the therapy choices for a thrombotic event, is Coumadin or warfarin still the preferred and gold standard anticoagulation therapy, or should we be thinking about alternatives, new ones, that are on the market?
Well, I'm not an expert on anticoagulation, but I would think that the standard approach would be intravenous heparin and then shift over to low molecular weight heparin or Coumadin. But I would, in this situation, because splanchnic vein thrombosis is such a dire event, I would bring in a coagulation expert to help me.
I largely view the novel anticoagulants for the individuals that really have issues around warfarin. So I view those very much as a very rich resource of second-line approaches, but still for the patient who does well on warfarin, both in terms of expense and really the safety factor of reversibility, it's my preference.
You brought a good point that there might be a need for another doctor to join from the laboratory perspective, from the benign hematology coagulation expert. Is there a need to bring a cardiologist in everyday practice in management of polycythemia vera patients if the patient has some cardiac history or suffers from the cardiac events, to work together as a team to prevent the clotting problems?
The clotting problems?
Clotting problems related to
The
cardiovascular events?
Oh, you mean a cardiovascular evaluation?
That's right.
Sure. I think obtaining an evaluation at least once can hardly be thought not to be advisable.
I find frequently if patients need a balanced team, if the team only has one viewpoint, their care probably is not as complete as it should be. So I'm very mindful that hematologists might focus more around the counts and aspects of the MPN, but probably not be as stringent in terms of cholesterol control, hypertension, and other risk factor modification as might be a cerebrovascular specialist or a cardiologist. So I think a balanced team is wise.
And in that sense, I don't think we know fully how exactly the statins, which would probably be ubiquitous in this kind of a situation, really affect the red cells and the platelets. After all, they have cholesterol in their cell membranes, and if I'm sounding like I'm rooting for them in this, that is doing something to them. Sure. By changing the quality of their cell membranes, you are changing their activity, you are changing their abilities to function. Maybe that's a good thing, because maybe if they've got a thinner membrane, they can slide by some constriction a little bit more easily. But we don't know exactly how much that is changing the day-to-day lives of the cells. And because we don't know that, we need to have somebody who can understand from a different perspective what they're trying to get out of it, and if that's real. And I think it would also, from just a patient's point of view, if all three of my physicians are talking to each other, I feel more comfortable than assuming that they're all going to read the computerized medical record.
Very good point. Thank you
Okay.
very much for a lovely discussion.
Thank
It was
you.
a pleasure. Thank you.
Thank you.
Thank you, everybody.
Thank you.